Hi, my name is Dr. Jennifer Lennahan. I'm a urologic oncologist at Providence St. John's Cancer Institute in Santa Monica. I'm Associate Professor of Translational Research here, and I'm excited today to talk to you about the different treatment options for kidney cancer. The good news for kidney cancer patients is that we actually have a lot of options. So I'm going to go through the whole gamma of all the different things we can do to treat tumors and how we can individualize and personalize that treatment for our patients. So when a patient comes into my office, I sort of have a standard conversation. And so the first thing we're going to look at is your images. How big is the tumor? What does the tumor look like? Is it in the middle of the kidney? Is it on the edges of the kidney? Does it look like it's touching anything else? Have you had other scans that show me, has the cancer gone anywhere else? So these are all important things that we were going to discuss. But really a lot of this is based on the pictures. So if somebody has a small kidney mass, and in some cases for me, even masses up to 10, 11 centimeters, depending on where they are, we'll talk about some different options. So let's just start by different size criteria. Most of the masses I see are probably about 6 centimeters and under. Number one, there is data that suggests you can just watch these tumors. And I will say in patients who are not great surgical candidates, or maybe have a very heavy history of cardiac disease, or already have bad kidney function, you might consider just watching these tumors. And there's very good data, especially in masses that are under 4 centimeters, that you can watch them for many years without any further harm to the patient. And we call this active surveillance because we know you have something there. We're not actually doing anything, but we're not ignoring it either. And so that's an important part of working through this with the patient. And there are some patients, again, that only may have one kidney. And so we may just be watching this tumor in the short run. The next option, again, depending on size and where the tumor is located, is that you can do something called histotripsy. And what this is, it's a ultrasound technology that uses bubbles to destroy the tumor cells. And the unique thing about histotripsy is that it doesn't actually go inside you, meaning it's not an invasive treatment. It's something we can do from the outside without even touching you. So this is going to be a great strategy to treat kidney tumors. Now, this is not prime time yet. Probably by the end of 2025 it will be, but we already have the Edison 1 histotripsy machine here, and we're going to be doing some clinical trials using it for kidney tumors. So again, we can watch the tumor, we can do something non-invasive like histotripsy. The third option, which is also very tried and true, is called ablation. And I keep it very simple for patients. I say we can cook it or we can freeze it. We either use microwave heat or we can freeze the tumors. Now this is more invasive because they actually have to stick a long kind of probe needle inside the body into the tumor, and then using a different energy, either heat or freezing, you can use radio frequency, you can use microwave, there are different technologies. You basically destroy the tumor. So this is good because it's minimally invasive. It can be done in an outpatient setting. Patients can go home the same day, minimal downside. And again, I would use this for patients who may not be the greatest candidates for surgery. Maybe they have some health problems with their heart or diabetes or their kidney function. And you can use this strategy to preserve as much kidney as possible for these patients, but still treat the tumor. What is the downside of doing that? The downside of doing any kind of treatments, even like histotripsy or like ablation, is that you don't know if you're cutting everything out. You never if you know if you're getting every last cell. But I will say that over the last 20 years, the risk of recurrence in those patients, if you look at the studies, is estimated from anywhere from about 12 to 18%. And that's recurrence of where you cooked or did freezing on the tumor, that it could come back there. And I think as those technologies have gotten better, that percentage is even dropping lower. And then the last treatment, of course, is cutting it out. And that's really sort of where my specialty comes in. So how I like to do these surgeries is we actually go through your back instead of your belly so that we don't involve any of the other organs. And we actually have a robot, a new technology that we're using called the SP robot, which is a very small robot. So I can get into these small spaces in the back and dissect and cut out the tumors. What is the benefit of that? The benefit of actually cutting out the tumor is that you know you got everything and everything's gone. The downside is it's an invasive surgery, which requires some reconstruction of the kidney. So when you have patients that already have kidney dysfunction, you have to be careful with that. When you have patients that have any cardiac issues, you have to make sure that those patients have clearance from their doctors. So we have a whole array of treatments, basically from watching your tumor all the way up to treating your tumor with surgery. And the discussion that is individual to each patient is, again, how big is the tumor? Where is the tumor located? What is the health status of the patient? What are their other comorbidities or things that they're seeing a doctor for? And we have to sit down in the office, go over the images, take all this into account, and then come up with the perfect plan for you. And I think in my business and the way I've practiced, I really focus on kidney sparing. How can I save as much of the kidney as possible, but still get good cancer control?